Blue background, I hope.
Looking good. Hi, Lauren. Good morning.
We are live.
Welcome everyone to the next session of the 5th International Ophthalmic Conclave on Ocular Oncology, Future Perfect, organized by AIOS. Over the next 36 hours in this conclave, we will be taking you 360-degree around the globe on a journey with the experts in the field of ocular oncology in this session, covering the latest advancements, techniques, and best practices in the field. Before we start the session, I would like to extend our sincere gratitude to our esteemed faculty, sponsors, and supporters for making this conclave possible to the different time zones, and your contributions are extremely invaluable. I now invite Dr. Prithvi Mrityunjay, the moderator of the session, to take over and welcome the chairpersons. Over to you, Dr. Prithvi.
Good morning, good evening, and thank you to the All India Ophthalmologic Society for allowing us to highlight some of the exciting work that's being done by our world experts in ocular oncology. Many of us have enjoyed just being in India last month for the International Congress of Ocular Oncology, so we are feeling the vibe and always the love from India. The group here today composes international experts that will be sharing latest research and clinical guidelines, as well as some very interesting cases. But we are overseen and supervised by two incredible chairpersons for this group. The first is Professor Dan Gombos from the MD Anderson Medical Center in Texas, who is the immediate past president of the International Society of Ocular Oncology, and our most esteemed Professor Jacob Pierre, who I will ask to please offer us a few comments as we start the session. Professor?
Thank you. Good evening, India. Good morning, America. Good afternoon, Europe and Israel. I speak from Jerusalem. And welcome to the joint symposium of the All India Ophthalmological Society and the International Society of Ocular Oncology. Last month, we had a great meeting of the ISOO in Goa, in which we learned so much, and I mean it. I learned things that I apply immediately. But we never want to stop learning, and here is another opportunity to learn and to enrich our knowledge. In the first part of this symposium, we are going to have several longer presentations on topics in ocular oncology, and in the second part, several case presentations with discussions of 4 minutes each. I would like to invite Prithvi to moderate this symposium and to introduce the faculty of the symposium.
Dr. Gombos, did you have a comment to welcome us, please?
He will conclude.
Okay.
So it's just a real pleasure to be here. And yeah, as Dr. Pierre has said, you know, the field of ocular oncology continues to evolve. And I think what is so exciting is to see where we were 20, 30 years ago, see where we are today, and know that the future is so amazing with opportunities that we never even imagined. So let's get started.
So to introduce our faculty, we have our chairpersons, Professor Gombos and Professor Pierre. We have expert panelists that are joining us. First is Professor Bhavana Chawla from the All India Institute of Medical Sciences, Professor Amin Kilik, who joins us from the Netherlands, and Professor Bertil D'Amato from the United Kingdom. Our faculty speakers today will start with Professor Sarah Lally, who joins us from the illustrious Wills Eye Hospital Oncology Service. We also have Sam Gurney, who joins us from Birmingham, from the Pediatric Ophthalmology Service. My good friend Hakan Demirci, Professor of Ophthalmology at the University of Michigan, and someone who is well known to this audience, Dr. Ferouz Manjandavida, who helped to organize the International Congress of Ocular Oncology to great success, joining us from Bangalore. We also have some fantastic cases from great teachers of ocular oncology from around the world. Lauren Dalvin joins us from the Mayo Clinic in Rochester, Minnesota. Vicky Dai, who has been a longstanding supporter of our international organizations and a great teacher. She joins us from Israel. Vishal Raval, who's a retina specialist and ocular oncologist from the LV Prasad Institute in Hyderabad. And finally, Dugante Rajanapurn, who is a leader in ocular oncology in Southeast Asia and joins us from Thailand. So this is an all-star lineup, and I'm really looking forward, and I'm going to take notes myself. But we'll first start from the front of the eye, and I request my good friend Sarah Lally to show us some things about conjunctival melanoma, and her talk is entitled The 5 W's of Conjunctival Melanoma. Sarah?
Great, thank you. Can everybody see my screen?
Yes.
Good. So actually, I think that lead up was perfect because currently we are writing this story on conjunctival melanoma. So hello and greetings from Philadelphia. I'm Sarah Lally from the Oncology Service at Wills Eye. And today I'm going to speak to you on the 5 W's of conjunctival melanoma: the who, the what, the when, the where, and the why. And I'm going to be spending a little bit more time on the where and the why. So let's begin. What does conjunctival melanoma look like? Well, we all know that it's an elevated mass that's usually pigmented on the surface of the eye with feeder vessels. It can be slightly flatter with variable pigment and extending onto the cornea. It can be hidden in the superior fornix and be multifocal. And it can also be an amelanotic nodule, which can be confused with a pyogenic granuloma. Anyone who has a history of conjunctival melanoma, if you start to see a melanotic nodule, it definitely makes you concerned because as it recurs, it can lose less and less pigment. And I can't understate, always, always, always flip the upper lid. So who gets it and when do they get it? Well, a study was done in 2003 looking at population data. And what we found in the United States was that conjunctival melanoma is on the rise, especially in the white, male, and over 60 population. This was not a trend in the female. We looked at it on the oncology service based on Fitzpatrick's skin type, which is a dermatology scale from less pigmentation to more pigmentation. Those with less pigmentation burn more easily and more at risk for cancers. And what we found was when it came to conjunctival melanoma, 85% of patients were type 1, type 2, being the fairer skin population. This population was also associated with older age, being female, decreased complexion-associated melanosis, smaller tumor size, and less likely to involve the eyelid. But there was no difference in vision, recurrence, exoneration, METs, or death. In addition, we also looked based on age outcome, and similar to other studies, the mean age was around 60 with a white population and fairer skin. There was no difference in male versus female or involving a left or right eye. But what was found was that older patients had more extensive disease and an increased risk for vision loss and tumor recurrence. So why does it recur? So I'm going to spend a little bit more time. We all know that cancer is caused by mutations. And we looked at over 100 patients with next generation sequencing looking at the mutations. And what we found was there was 40 different gene variants. Most commonly, the high-frequency mutations, as seen in other studies, was in NF1, BRAF, NRAS, and ATRX. Well-documented skin melanoma mutations weren't seen as frequently as seen in CDKN2A, KIT, and PTEN. We did find a certain subpopulation that had similar uveal melanoma markers, and they did occur along with ATRX, NRAS, and BRAF. And this has also been documented in cutaneous blue nevi melanoma and primary orbital melanoma. So really, there's distinct biological groups and can be classified into those that are similar to skin melanoma, like those that have the BRAF and the NRAS mutation, those with CNS neural crest, like tumors with the NF1 and the ATRX mutation, those with uveal melanoma signature markers, and those patients, about 5 of them we found had no pathological variants. ATRX and NF1 were associated with a lower rate of METs. BRAF was not associated with increased risk of METs and death, and NRAS had a higher rate of METs and death. And so that subpopulation you need to follow very carefully because they're at increased risk for recurrence on the eye and metastatic disease. So where does it come from? Well, back in 2011, our service looked at over 300 patients, and what we found most commonly arise from primary acquired melanosis, followed by de novo, and then nevus. But there was no difference in age, gender, race, or eye. So then we thought, okay, there's many mutations going on here. We're not right sure what is causing it. And so is there some UV signature or sunlight exposed like skin melanoma? Most skin cancers are caused by sunlight exposure, and there are known mutations that cause these cancers. They're typically called UV signature mutations. And then there's other non-UV light mutations like the NRAS and the BRAF that are seen in skin melanoma that cause cancer, but are not necessarily the UV signature mutations. So we thought maybe, is there a correlation between where the cancer is located on the eye and having the known sunlight mutations? So we divided the eye into 17 different locations and looked in those areas that were definitely UV exposed versus not. We looked at these known mutations to try to figure out, well, is there a UV component causing conjunctival melanoma? And what we found was tumors could have more than one mutation, but there was more common UV light mutations in 90 of the specimens. But if you had multiple UV light with a non-UV light, you were automatically considered a UV mutation. You had to have no UV light to be considered a non-UV light mutation, but there was no difference in age, race, or sex. In addition, then we looked at these mutations based on size, thickness, pigmentation, and there was really no difference except for the non-UV mutation was more commonly seen in the tarsus or non-exposed area. But when it came to sunlight exposure, the sunlight mutations were not seen more commonly in a sunlight exposed area. In addition, there was no difference in PDL1, tumor mutational burden, tumor mutational load or microsatellite instability. It was noted, though, that those with the non-UV signature mutations were more intermediate tumor mutational load, and those, as expected, with high tumor mutational burden were more likely to be UV exposed. The UV, non-UV light related mutations had an increased risk for METs, but there was no difference in survival. So again, the UV exposed were more likely to possess non-related mutations. The palpebral location was more likely to have non-UV light related mutation. There was an increased risk for METs in the non-UV light related mutations, but not survival. And really further investigations into the role of tumor mutational burden and microsatellite instability is needed. So currently we are writing the story on conjunctival melanoma. The incidence is on the rise. We know it's a pigmented lesion on the surface of the eye, typically seen in the fair-skinned population in the 50 to 70-year-olds. It can arise from primary acquired melanosis, nevus, or a de novo. But really, the where and the why has been harder to define, and that becomes the next stage to this story. Thank you.
That was wonderful, futuristic, and a lot to think about. Thank you so much, Sarah. So I'll start the questions to our panel to begin with. So Sarah has really provided us some important molecular data that's guiding classification of conjunctival melanoma. One of the, I think, less defined areas is how we screen systemically for metastatic conjunctival melanoma, timing, the type of test that we use, et cetera. So I'll open it to Professor D'Amato. With this information now, if I know that I have an NRAS mutation, would you change the frequency or the type of screening for a conjunctival melanoma patient, and maybe tell us how you screen these patients systemically?
So I think the first thing to do is to estimate the risk of metastasis in 10 years. And then what we've been doing in Stockholm is to follow the guidelines of a European group dealing with screening for metastasis from cutaneous melanoma. And so if the risk is low, then it's just palpation of the lymph nodes in the neck. If it's higher, then they recommend ultrasonography of the cervical nodes. And then after that, if it's higher still, then it's systemic imaging. And if it's even higher, then they also include CNS imaging as well. But it's difficult to find printed guidelines for conjunctival melanoma screening. And I wonder what the other panelists think.
Any comments on known guidelines or a good working reference for screening for metastatic conjunctival melanoma? Sarah, maybe you can give us your thoughts too.
Definitely, the studies have shown in tumors greater than 2 millimeters in thickness, those patients automatically get a sentinel lymph node. We end up, so we'll present them at our tumor boards with our medical oncology, our ENT people. And so based on what the tumor, we call it, looks like, if it's looking more aggressive, if it's very extensive, even if it's not 2 millimeters in thickness, but it's kind of covering the entire eye, or it's in multiple locations, our medical oncologists will start to talk to these patients about trying to do something preventative. There is no data out there. There is no study looking, but our NRAS positive make us more concerned. Those with bigger tumors, we will, and it is hard here in the States to put people on these immunotherapies because they're so expensive, but they will kind of find a loophole, and the cutaneous world is definitely dictating how they can be treated, and that's usually what they follow.
I like how it looks. I think we all use that in terms of just extent of disease, but I think that's very true. Dr. Gombos, any experience at MD Anderson with putting patients prophylactically, empirically on targeted inhibitors based on mutations for conjunctival melanoma?
Yeah, this is sort of a great area. First, a couple of things. We all understand and agree with the utility of sentinel lymph node biopsy. That said, we really don't have evidence that getting a sentinel lymph node biopsy alters overall prognosis. It may upstage a patient. It may open them up to a wide dissection. It may then make them available to many treatments. But that link, I think we have to be very cognizant of when we counsel our patients about all these things, which I don't think we always do. The next question that you point out is neoadjuvant. And of course, in the field of advanced stage 3 and stage 4 cutaneous melanoma, Sapna Patel had a very nice sentinel paper in which he demonstrated that neoadjuvant in the setting of advanced cutaneous melanoma had better overall life prognosis than traditional approach, which is surgery and then adjuvant immune-based therapies. There's no doubt that many in my melanoma medical oncology cohort will be open to considering neoadjuvant in the right patient. But a couple of points, as Dr. Lally pointed out, this is expensive. This is not candy. These have significant toxicities. You need to think about the potential toxicity, and you need to pair with a melanoma oncologist willing and open to consider neoadjuvant as opposed to what we've done traditionally. And I think people who are heavily based in cutaneous melanoma have maintained the literature in that field and understand the parallels, may be very open to that.
Thank you very much for a great discussion. We'll move on to our next speaker. Our next speaker is Sam Gurney. Sam is a consultant ophthalmologist at the Birmingham Children's Hospital, which is one of the major retinoblastoma centers in the United Kingdom. And he'll be talking on a point very important for the Indian audience, the role of OCT in retinoblastoma. Sam, take it away.
Thank you, Prithvi. Just while I'm sharing my screen, thanks to the organising committee for the opportunity to talk to you all. Hopefully my screen's now visible.
Perfect.
So, perfect. So my name's Sam Gurney, a consultant ophthalmologist in Birmingham, and I'd like to give an overview and a bit of an update on our use of OCT imaging in retinoblastoma. I've got no relevant disclosures to declare. So I'll talk a bit about the role of OCT in diagnosis of retinoblastoma. We found it particularly useful in differentiating other lesions that could mimic RB. And in particular, we found it useful in some management decisions for some difficult cases, which I'd like to share with you. So as we know, the technology and the literature around it has really exploded over the past couple of decades. And in terms of our use of the technology in Birmingham, initially we had a bioptogen, and more recently in the past 2 or 3 years, we've had the Heidelberg Spectralis Flex, and the images in the presentation will be have been taken on that machine. So the majority of the time with a new retinoblastoma, you don't need an OCT to tell you that it's a retinoblastoma. But sometimes there is a tumor that may be invisible or near invisible. The arrow is pointing to one there that is very well characterized on OCT imaging. So this can particularly be useful in, screening fellow eye if we're worried about a germline cause of retinoblastoma. And Shields et al. Have sort of characterized the findings of an intraretinal tumor, early intraretinal tumor in RB with what's called the shark fin and fishtail configuration, which is a change in the outer and inner nuclear layers respectively. You can see this fusiform contour to the tumor, and importantly, we'll see the difference later on in the talk. Importantly, there's typically no post-acoustic shadowing behind the tumor. So in contrast to retinoblastoma, other tumors like a hamartoma look very different. So the first thing is, rather than being arising from the nuclear layers, these are arising from the inner retina, the retinal nerve fiber layer, ganglion cell layer. And also they tend to have a much slower growth velocity than a retinoblastoma would. So imaging and serial imaging in particular can be helpful. Likewise with a hamartoma, with time, you do often get this moth-eaten appearance due to this intralesional lucency that you can see on the scan. So all of these features are very much in keeping with a hamartoma as opposed to a retinoblastoma. A blood vessel on an OCT, as you know, will cause a small area that in theory could be mistaken for a tumor. This is where looking at both the slice of the OCT, but also the on-fast picture is helpful. You can see on the on-fast that the elevation is directly over a blood vessel, and we are seeing a small amount of post-acoustic shadowing, which helps you to differentiate this as a retinal vessel as opposed to an early tumor. We also know that there is physiological thickening, particularly around the larger vessels, and again, correlating what you're seeing on the OCT with what you're seeing clinically, and the level of that section is important. So this is completely normal thickening near a blood vessel. And again, on the OCT image, you can see quite nicely the post-acoustic shadowing behind the blood vessels. So this was a case, a child had been treated with intra-arterial chemotherapy, followed by consolidation laser treatment. And from one EUA to the next, there was a concerning area, which is highlighted with the blue arrow, which on clinical examination and on RET-CAM imaging certainly could be mistaken for a retinal or potentially a vitreous recurrence. And in that context, we'd be escalating management to intravitreal chemotherapy. But actually the OCT was very useful. So you can see the middle picture corresponds to the RET-CAM image that I showed you on the last slide. And what we were seeing there really did not look like a vitreous, did not look like vitreous disease. It was much more in keeping with a vitreous hemorrhage, most likely as a result of previous laser treatment. And you can see that actually the following month that had cleared completely, albeit with some vitreous fibrosis, but it reassured us that this was not a disease recurrence, and the child did not need to go have an escalation in treatment. We see scarring a lot as a result of often the laser treatment that we're giving. And so this slide just shows how scarring, and particularly retinal pigment epithelial hypertrophy, does look different to retinoblastoma, which is important. So here you can see quite significant central shadowing behind the scar with some peripheral lucency, and differentiating active disease from scar, and thereby giving us a clue as towards endpoints of treatment has probably been the most useful part of the OCT journey that we've been on to date. So this is an example of a child who'd been treated again with chemotherapy followed by consolidation laser, and things had been going in the right direction, sort of reduction in viable disease at each visit. But from one visit to the next, you can see there was an increase in this translucent material, almost like a sheet. And we do occasionally see retinoblastoma recurrence in a sheet like configuration. So this was clearly, again, a concern for possible regrowth. But again, the OCT was reassuring. We can see the slice there through this area of increased translucency was not in keeping with disease activity, but rather with fibrosis, again, as a consequence of the laser treatment. So rather than escalating treatment, this gave us information and reassurance actually to step back from laser. Otherwise, you precipitate a vicious cycle of laser fibrosis. So the OCTs helped us to some extent to break that cycle in many cases. This is a boy that we first saw at 3 days of age. So his mother had been treated for retinoblastoma in childhood. He had bilateral retinoblastoma essentially at birth. And the OCT in this case, the pictures are interesting, but it helped us really know that we needed to try and reduce these tumors away from the foveas before starting any focal treatment like laser. So this child had systemic chemotherapy for chemo reduction of the tumors prior to laser treatment to try and minimize the visual morbidity that our treatment would cause. This is another child that we've treated, this time with intravitreal chemotherapy. And this child had some toxicity to the chemotherapy with cystoid macular edema, and the intraoperative OCT the Flex OCT was helpful in being able to monitor response to treatment. And as you can see over time, the cystoid macular edema resolved and the vision improved significantly. And just a few kind of interesting pictures that we've picked up over time. This was a sub-ILM fluid that developed as a reaction to laser treatment. And again, over time, we can see that resolved quite nicely. Anterior segment OCT, confirming here lens touch, which obviously in retinoblastoma is one of the important features that would classify as an E. So being able to see that and document it so clearly with imaging is helpful. And the final case of a child, not with retinoblastoma, actually, they're treated for medullopithelioma with plaque therapy. And a few months later, in their better eye and essentially only seeing eye, they had a reduction in vision. And this is what we were presented with at EUA on the RetCam image. And it's just to show that actually, even with a view, a vitreous as hazy as that, the OCT is able to see through. And other parts on the examination, combined with this OCT picture, really pointed us towards this child having a sympathetic ophthalmia as a result of the plaque in the other eye. And this child was treated with steroids and is now on methotrexate and adalimumab, and has had a good response. There is still some vitreous haze, but these multifocal serous detachments you can see on the OCT have since resolved. Just a few things that we've learnt over time that can be helpful. The Flex OCT is quite a bulky machine, so often having more than one person to kind of maneuver it is useful. And actually, you can position the camera, but you can also position the head and the eye under anesthetic. So all of these things can be combined to really get quite peripheral views at times. The image quality is very reliant on the cornea not drying out. So it's an important job for one of the residents to keep the cornea watered with saline throughout. We found that using both horizontal and vertical line scans can kind of tell the whole story often. The OCT struggles with particularly elevated lesions, and so starting in a flatter area of retina definitely helps. The OCT by default would try and take often quite a large field, which if it's a tricky picture to acquire, making the field smaller can often help as well. And typically new reference points are needed over time as the tumor or scar evolve.
Great. Sam, can we maybe move to some questions?
Sure. Yeah. So
Thank
that was
you.
at the end there. So thank you to my colleagues, and thank you all for listening.
Thank you, Sam. Great images. Bhavna, I'm going to go straight to you. Can you tell us how you incorporate OCT in the management of your children? And specifically, are you using it when you think there's a problem, or are you just using it also as a screening method, broadly looking at all maculas or all areas of within the eye?
Yeah, thank you, Prithvi. So firstly, Sam, that was a wonderful presentation. I loved all the pictures and very nicely explained the role of OCT. So Prithvi, in our setup, so we, usually do not use OCT routinely as a screening tool. It kind of adds to the GA time. And, in our setup, we see like most of the times we're seeing very large tumors. So kind of the role of OCT is limited in that situation. But yes, in many situations, like, we also encounter where, we feel that we want to differentiate retinoblastoma from a simulating lesion. We're not very sure on clinical examination what we're looking at. Or sometimes also, like Sam very nicely showed through his cases, where, clinically you don't know whether you've reached an endpoint of treatment. You have a fish flesh kind of lesion. You're not sure if it's active or inactive. that is the time when OCT comes in very handy to tell us that whether, we're not over-treating, whether we can stop treatment and sort of. So that is the second situation. And the third, which also Sam mentioned, and I do remember in a couple of cases where we've used OCT, is, in a case of a hazy media, where we where we have a limited view of the fundus, that is when OCT has been helpful in guiding further treatment. So that's, kind of sums up, the role of OCT in our setting.
Excellent. Thank you very much. Well, we know that the incidence of cancer is going up around the world and also in India, unfortunately. So we'll be seeing more and more patients with choroidal metastases. Professor Demirci from the University of Michigan will tell us about his work with innovations in the management of choroidal metastases. Hakan?
Thank you very much. It is on the slide. It's on the slideshow.
Awesome.
Perfect. Great. Thank you very much for this opportunity and to be back and to be back maybe virtually in India again right now after a month later. So today I would like to talk about some of the innovations in the management of choroidal metastasis. As Prithvi said, the choroidal metastasis is the most common intraocular malignant tumors. And about, like in the United States, we are estimating around 30,000 patients per year. And what do we have in our arms for the treatment? The external beam radiotherapy, it is the most commonly used one. In very selected tumors, we used brachytherapy as a form of a radiation. And we know that with this current treatment, with the advances in the current treatment, in the targeted therapies, immunotherapies, and some of these metastatic tumors also respond to these treatments also. But we know that these patients has poor survival. In all time, in the previous studies, we used to say that the breast cancer patients live around 24% at 5 years maybe. But now with the new advances, maybe this survival time is maybe increasing right now, and the patients are living longer. And also, as the awareness of the choroidal metastasis or overall the intraocular metastasis increases, then we start to see the metastatic tumors is in much earlier stages right now. So can we come up with other treatment alternatives that we used for years, like in addition to the external beam radiotherapy or brachytherapy? One of the options that we used for the choroidal metastasis also in other metastatic in the other parts of the body was the photodynamic therapy. We know that for example, if you look at the photodynamic therapy, how it works, we know that it induces the thrombose formation in the endothelium-lined structures in the blood vessels. And the choroidal metastasis is a very vascular lesion. So it makes that the choroidal metastasis is an ideal target for photodynamic therapy. And in the literature, if you look at it, almost in 10 years, in the last 10 years, we see multiple papers about the photodynamic therapy and its effect on the choroidal metastasis. And recently, there was even a review, a meta-survey analysis for all the literature. And they summarize it very nicely for us, actually. They noticed that if you do the photodynamic therapy, you significantly increases the tumor regression in the tumor control, actually, in these patients. But although photodynamic therapy effectively decreases the tumor thickness, they didn't notice any change in the vision. So we control the tumor, the small tumors, but we couldn't make an impact on the vision. So what are our options right now based on this knowledge? And now also I want to put want to mention one thing is there's a kind of a new coming study is that right now we know that there is a viral drug conjugates, and that has been in trials right now for the choroidal metastasis. And most of the people in this panel and then in this panel and in this talk will be one of the centers for this viral drug conjugates that we are going to admit suprachoroidal injection and then see the effect of this treatment, how it will affect for the choroidal metastatic lesions. But if we come back to the same question again, like if the photodynamic therapy is really effective in the tumor thickness control, but the problem in the vision, is there a way that can we increase the effectiveness of the photodynamic therapy and at the same time improve the vision? So what we know that in the photodynamic therapy is when you apply the photodynamic therapy to the tumor, it causes the thrombus formation in the tumor cells, in the tumor vasculature, that leads to the necrosis of the tumor. But at the same time, this environment that causes lots of angiogenic factors to be released, and that is also leads to some side effects. And then maybe that the release of the antiogenic effects can play a role that why we don't see such a significant effect on the vision when we just do the photodynamic therapy. So there are some animal studies, actually. They look at this idea of tumor control and angiogenic factors for the photodynamic therapy in the animals and in the other different part of the body. They did this animal study. They did the photodynamic therapy to the tumor in the animal first, and then they look at the tumor control, and then they try the anti-angiogenic factors. For these ones, the Avastin, for example, and then they look at that if we give the Avastin with the photodynamic therapy, can we increase the tumor control? And they found that if you combine the photodynamic therapy with the Avastin injection, actually you can increase the tumor control. And also they found that the timing of the tumor injection, if you do the injection after the photodynamic therapy, you see the most prominent and most significant effect. Look at that. In this graph, the blue line, the bottom, is the first photodynamic therapy, followed by the Avastin injection. You can see that the tumor volume is the smallest over there at the end of the follow-up. If you look at that, the photodynamic therapy only, which is the red line, during this time, you can see that you don't see the similar effect by doing only the photodynamic therapy. So if we apply this thinking actually for the choroidal hemangioma before, combine the photodynamic therapy with the Avastin, and then we noticed that adding the bevacizumab or Avastin into the photodynamic therapy, you increase the visual rehabilitation significantly compared to the only applying to the photodynamic therapy. So we start to do this one. I started this one, treating the patients with first full fluence photodynamic therapy, and then usually next day or in a week, give Avastin injection, and then follow them how they are going to respond to combination of photodynamic therapy with the Avastin. And then now our numbers are a little bit more increased, but at this first analysis, we look at the choroidal metastatic tumors less than 3 millimeter in thickness with the localized subretinal fluid. And then in this one, we look at around like 41 tumors. And then there were naturally, like by the timeline, happened in two groups. One in the photodynamic group in 22 tumors, and the other is photodynamic therapy with the Avastin, followed by Avastin injection in 19 patients. And as you can see, the primary tumor sites was breast, lung is the most common, and the others. So almost turn out to be two equally numbers of tumors in two groups. And then we look at these two groups. If there is any really effect in tumor control or the vision between these two groups. These two groups turn out to be almost very equal in demographic features or the tumor features or the laterality involvement. And then so what we observe actually is if you if you look at,
Hakan,
if you give summarize it.
Hakan,
Yeah.
yes, thanks.
Okay, so what we see basically, if you do the photodynamic therapy combined with Avastin injection, you provide a significantly better vision control in 6 weeks. And then similarly, the tumor control is significant. The tumor thickness remained the same. And then, so basically what it shows, the combined photodynamic therapy with Avastin injection provides the faster and better visual tumor control, vision recovery compared to the photodynamic therapy alone. And the vision tumor control was almost like more than 70%. So we need to learn, I think, more about these things.
Thank you, Hakan. That's really an innovative approach. Amin, can you start us off? In these days now where patients have options of targeted therapies that may also impact the eye, in your service, if you see a patient who develops a new metastatic lesion and you're seeing them for the first time, do you proceed with local eye therapy, or do you like to see how the systemic therapy might work before something directed to the eye?
So in these days, my approach is if the patient...
Hakan, hang on, Hakan, you're very good.
Yes.
I'm going to ask Amin. Amin's going to answer that first,
Yeah.
and then you can answer that.
Yes,
okay.
thank you. In our service, we will first wait and see how the systemic therapy evolves, because the majority of the patients will respond to the systemic therapy. Even though the other metastatic sites will grow, the eye will respond very well. So, and if it doesn't respond, then we go, depending on the size of the lesion, go to either stereotactic treatment, or we will do external beam. And I really think it's interesting for the PDT, but unfortunately in Europe we have a very low amount of verteporfin, so we're obliged to use it just within a certain schedule, so we cannot try it within these patients. And then for Hakan, would you use this as a first-line treatment, or maybe a second line after you see that the hormonal therapy or any other therapy for the, which we will use in general, will not, that the patient will not respond? Because using it as a first-line treatment for a group of patients that will, maybe 50% doesn't live by the first year, is quite a burden, maybe a burden for the last years, last months of a patient, just have such a heavy, like the regular checkup. So.
No, that's a great question. I think that's a great point. I think currently what we are doing is just when the patient started with systemic therapy, either targeted or immunotherapy, whatever the treatment is, they are on. If it's a very fresh patient, we give about 2 or 3 months, just a close follow-up to see if the lesion is responding. If the patient comes to me as previously the patient is on therapy, on immunotherapy or whatever therapy it is, and then still has the eye problem, and then I still see the subretinal fluid or that the choroidal lesion, then I directly go and then treat these patients basically.
And do the oncologists switch the therapy then, if they see the lesion?
Yes, that's another good point. But if the rest of the body is responding well and there is no recurrence in the rest of the body, they don't switch based on the eye findings actually. And we just locally treat and watch them systemically.
A quick question, Bhavna, if you could be brief. In India, what is the preferred treatment options for metastases of the choroid? Can you help our audience understand radiation, systemic therapy, or photodynamic therapy?
Usually when we see a case of choroidal metastasis, like, it's the call of the medical oncologist and the surgical oncologist and the radiation oncologist. It's the team that, takes the call and decides how to manage the patient. And we usually wait for, systemic treatments to work, or, whatever response that we get from systemic treatments, usually do not proceed with any local treatment.
Thank you very much. Our next speaker,
Dr. Prithvi,
actually, we're gonna move on to your talk first, and maybe we'll come back.
Just a comment. It's regarding the availability of verteporfin in India. it's very difficult to procure it at this point of time. So we're not even using PDT for choroidal hemangioma in India at this point. Yeah.
I think that's a challenge around the world, actually, as we're hearing.
Yeah, so
Thank
there's
you
no
for that point.
availability. Yeah.
And with no further ado, I will introduce you, Dr. Feroz, who requires a little introduction to the All India Society. You'll be discussing with us an update on orbital tumors. Dr. Feroz.
Thank you, Dr. Prithvi, and good morning, good evening, and greetings to all of you. I have been missing all of you after the ISOO, and it's like a welcome back to this All India Ophthalmological platform. Very glad to have you all back, and we continuously prove that we cease to stop to learn again and again. So thank you, Dr. Prithvi, for organizing this wonderful meeting here today. And it's my honor, and I'm humbled to be part of this stalwarts who has been, highlighting all the newer modalities and important aspects of ocular oncology at various arenas. So I take the responsibility to present on the update on orbital tumors. Well, it's an extensive topic, but I'm just gonna touch upon the very, very crucial ones in the next 8 minutes given to me. These are my affiliations and financial disclosures. So the basic guiding principle of any orbital tumor is thorough clinical evaluation, good imaging technique, good systemic evaluation, and then choosing the appropriate management for the better outcome of the patient. Let me take you through a few updates in orbital tumors. This 11-month-old baby girl with bulging of the left eye. In fact, she was referred as a case of squint. On systemic evaluation, well, we saw these cafe au lait spots, so we know what's going on in the eye. A fundus evaluation revealed optic atrophy of the left eye and a slight hyperemia of the nerve in the right eye. And imaging modality with an MRI, we found that it's a bilateral optic nerve glioma, where it's more in the left eye. Genetic testing was done. And this is a sequential way of diagnosing this tumor. Now, there's nothing new about optic nerve glioma, but I'm going to highlight a few very, updates in it. We all know that it's associated with neurofibromatosis. Now, although we know the WHO grading where grade 1 and grade 2, and mostly we get the grade 1 juvenile pilocytic astrocytoma in these patients, some optic nerve glioma can have an aggressive behavior, which accounts to 3%. And there is something called MIB1 labeling index, which is newly that we look into in order to differentiate these from the less aggressive ones. Now, the most important update is the treatment of optic nerve glioma. So the options that we have now at this point of time is systemic chemotherapy. Vincristine and carboplatin was the chemotherapeutic drug that was used in this baby. And as you can see here, she has very well, and the outcome has been a regressed optic nerve glioma, including the reduction in the clinical reduction in the proptosis over here and complete regression and non-progression of the tumor in the good right eye. Now, other options are MEK inhibitors, selumetinib. It is FDA approved. Well, I don't have personal experience with it. And also anti-VEGF bevacizumab has been recommended in optic nerve glioma, and that's a treatment update. Now, why is it so important? I'm just going to take you to this case where this child was diagnosed to have an optic nerve glioma when she was 1 year of age, where the physician and optic nerve glioma being a benign tumor decided to observe, and this is how it progressed, where as you can see in her left eye there is absolutely no fixation, so she is blind and also cosmetically disfiguring in the eye. When the parents came to me, they didn't come for the treatment of optic nerve glioma. They in fact came for a cosmetic rehabilitation of the child, and where a large tumor has to be excised and an implant and a prosthesis has to be given. So the learning from this case is that we should be exploring the newer modalities of treatment in optic nerve glioma in order to prevent the progression, not only of the eye, which is more, but also to avoid chiasmal progression and optic nerve extension to the other eye and preventing blindness in these children. 23-year-old a lady, left eye, rapidly progressive proptosis with a cornea melt. This is how she presented. With a large tumor, as you can see here, the globe has been pushed to one side, and clinically you can see that the cornea has melted over here. Now, this is how the tumor has progressed, and she was referred from abroad, where she had to apply for the visa, and this is how much the progression was within 1 year, which is very, very clear that it's a malignant lesion. Surgery was done. This was how the maximum debulking of the tumor that I did, and it came out to be a rhabdomyosarcoma. Well, we all know that rhabdomyosarcoma is the most common orbital malignancy in pediatric age group, but we can have extremes of age where this patient presented at 23 years of age. Now, what has changed? Well, we all know that historically and, rhabdomyosarcoma has been classified as embryonal ARMS and alveolar ARMS, and there are certain other criteria that we consider in order to plan the management. And we all know that alveolar has a poor prognosis and embryonal has a better prognosis. So what I want to highlight here is it's nothing new, it's not an update, but considering the excision of the tumor, we should always aim for maximum debulking and maximum excision with very, very microscopic residual of the tumor, which will take it into group 1 and group 2, which will give it a better prognosis as far as long-term mortality and recurrence is considered. Now, what is new in rhabdomyosarcoma, which is really promising, is molecular testing. Now, what we do is we look for the fusion of these genes, the fusion of PAX3 and FOXO1 and PAX7 and FOXO1 is considered to be one of the most important prognosticating factor in RMS. From pathology, basic pathology to IHC, now we have come into molecular genetic testing as well. So the fusion positive ARMS has considered to be poor prognosis, especially which is PAX3. So to conclude from this paper, which highlighted very, very important aspects of RMS and update on RMS, they also found that good prognosis in RMS is anywhere from age 1 to 9 years, group 1 and 2, which we always know, size less than 5 centimeter, and the fusion of PAX7 and FOXO1 is better than PAX3 and FOX1. And my medical oncologist does this in all my RMS patients at this point of time, and that's an update. So this was an ERMS, low risk, group 2, fusion negative. And what she received was chemotherapy and orbit radiotherapy, and this is how she went back to her home country. 76-year-old lady, right eye looking smaller than OS, 6 months duration, and she was referred for ptosis surgery for an acquired aponeurotic ptosis. Well, I was not too comfortable seeing that. She had a little bit of fullness in the periocular area superiorly, went ahead doing an MRI, and she's a known case of CLL, where she's under observation and not undergoing chemotherapy, which was diagnosed 15 years back. So she had this lesion in the preseptal area, in the upper eyelid area and the superior orbit. So, well, I went ahead doing an excision biopsy. It was almost maximum debulking of the lesion, and this is the extent of the lesion, although extending laterally and medially, and this is the markers. And well, I want to highlight how important immunohistochemistry is. Well, it's not new, but there are still centers who doesn't do adequate immunohistochemistry to actually know the type of the lesion, grade the lesion, and know the severity of, lymphoma. So it's so very important to play with the immunohistochemistry and, get to know appropriately what tumor you are dealing with. So this was a case of extramarginal zone lymphoma. Her PET scan was done, which is also mandated and indicated in lymphoma, ocular adnexal lymphoma. And what new that I did in this case was ultra-low dose stereotactic radiotherapy. It was 400 centigrade into 2 fractions, 200 and 200 in 2 days. And this is also called boom radiotherapy. Well, it has various advantages, minimal side effects, good control rate, short duration, and cost effectiveness. And this is how she looked like. So we know the treatment strategies of ocular adnexal lymphoma from surgery, radiotherapy, systemic immunotherapy, and systemic chemotherapy. And the conventional dose is 2,400 centigrade. And what we have seen recently, and the update is the ultra low dose radiotherapy. And this is what we learned from Dr. Bita Ismaili. And well, I do follow this in my patients currently. And also local injection of ocular rituximab. Thanks to Dr. Hakan Demirci for writing this paper. And this also, gave us an insight to this particular treatment, which is more localized. This was my first case of, almost finishing, Prithvi.
Yeah, thank you.
Ultra low
Thank you.
dose injection rituximab in this patient where there is complete resolution of the tumor. Now, quickly, last case, 27-year-old gentleman, left lacrimal gland adenoid cystic carcinoma. It was diagnosed elsewhere. What he had undergone was incision biopsy diagnostic. Then he went for orbital radiotherapy. And when he presented to me recently, after all these things, he had a tumor growing in the eye. And so 1 month later, he came up with optic nerve compression and reduction in the vision. So we had published our series on multimodal treatment protocol, but this patient did not receive that. It was just orbital radiotherapy, which was given with the tumor progression. So we have found that with the combination of neoadjuvant chemotherapy, surgery, radiotherapy, and adjuvant chemotherapy, we have found better tumor control as far as recurrence and mortality is concerned, and eye salvage and vision salvage. So in lacrimal gland carcinoma, that is what adenoid cystic carcinoma, we would definitely consider multimodal treatment protocol. So is Ewing sarcoma. So Prithvi, I'm just gonna conclude.
Thank you. Wonderful talk, great images, difficult cases. So all of these papers now are open for discussion, but I want to start with a comment on Feroz's talk. Vicky, could I ask you, there's so much information that we've learned about lymphoma from you and your colleagues in Israel. How do you approach conjunctival or orbital lymphoma? Are you using lower dose radiation? Can you guide us through that a little bit, Vicky?
Yes, thank you for asking, and thank you everyone for the wonderful presentations. We do apply very low dose of irradiation, and we see very little side effects. It's very effective, and patients are happy, and we are happy. But we do follow the course both systemically and locally for almost a lifetime.
I'll be honest, I like the fact that it's so low dose. I've also seen more recurrence than I've seen with the more standard dose. And then our radiation folks will just be like, well, do it again, another 2 or 4. So I don't know how safe that is. I see Dr. Gombos shaking his head. Dan, any comments on that? Boom, boom is not always awesome.
So I'm so glad you said that because, of course, I'm an institution that strongly advocates. I mean, our radiation oncologists will not even give me the option anymore. And it's very challenging at times. I tell them, I say, the traditional dose, which is significantly higher, as Dr. Feroz pointed out, but was exceptionally well tolerated. And these tumors would melt. They would disappear. We would see nothing. And now patients are happy, as Dr. Dye points out, it's like boom, boom, they're done. But we never see that sort of complete regression. There's always this little residual. And the radiation oncologist will tell me, is it growing? And I'll say, no, it's not growing, but it never used to be here. And they have become so committed to this ultra low dose. And if you really read the papers, there is a higher rate of local recurrence. So they're not surprised. They'll still say, yes, we'll do it. And then only if there's local recurrence will they go to a more traditional dose. So it's a very, I don't even win the arguments anymore with the radiation oncology team. I've given up, but they will acknowledge that there is a higher local recurrence rate. So I'm curious what the others have experienced. And I noticed that Hakan did have to do these injections. Is that because he saw higher local recurrence rates?
Hakan, quick comment, and then we'll go to Professor Pierre.
Dan, I definitely agree with you. And also the second thing is, if you look at these papers a little bit more carefully, and then if you look at the complete response rate and then the partial response rate, then you will see that the complete response rate is actually low. When you combine the complete and then the partial response as a response, that's high. But that is a very tricky point, and I definitely agree about that. And that's what I try to intralesional Rituxan as a first choice. And if it doesn't come, then go to the full dose radiation. But I'm not
Pierre?
against the ultra low dose.
Most ocular dental lymphoma, and especially conjunctival lymphoma, are mild, very low-grade lymphomas. Whenever, if it's just in the posterior part, let's say behind the equator, in the orbit, we are not afraid to irradiate it with low dose. But whenever it's conjunctival, we are very careful, and in irradiation, we try not to irradiate. So if it's just localized, we may inject rituximab into the lesion. If it's more extensive, we give systemic rituximab. And yes, not always it disappears completely, but even if it doesn't disappear completely, it doesn't change for years, and it does not threaten life, or it's just stable, and that's it. So we try not to irradiate the anterior segment of the eye.
Kind of extending this to intraocular lymphoma, I know that we all really favor the use of local chemotherapy in many cases when appropriate. Has your center been looking at low-dose radiation for intraocular lymphoma, or is that not gone boom boom yet?
No, for intraocular lymphoma, we will try to use like local treatment, intraocular chemotherapy. But also our radiation oncologist might be a little bit more conservative and just go full dose, and then be reluctant just to do the boom boom.
I'm sending my patients to the Netherlands.
In the last 28 years,
Yes.
years, we didn't irradiate any vitreoretinal lymphoma. We just did them with intravitreal chemotherapy. With
Bruce?
Yeah, Dr. Prithvi, not a question to you because you do mostly retina, right? Let me ask this question to Dr. Hakan. Hakan, doctor, you might have done ultra-low dose radiotherapy in your series. Have you done any, and how many?
I mean, I start with intralesional Rituxan injection
Always?
first.
Okay.
Always.
If it's CD20 positive.
If
Yeah.
it is low dose, like if the low-grade lymphoma, either it's a mild or follicular lymphoma. I don't do the intralesional Rituxan for the high-grade lymphomas.
Yeah.
Just for malts and folliculars, basically.
Okay. And then after that, you go for a ultra-low dose? That's how you do it?
Yes. Actually, like after the intralesional Rituxan, if there is a recurrence, it's coming either low dose, or our radiation oncologist like a little bit go to the classical dose, actually. I have to talk with them and convince them if they need it, basically.
And Dr. Hakan, you being an orbital surgeon, I mean, just kind of highlighting regarding the surgical debulking of lymphoma. Do you go for maximum debulking when you go in, or you just take a small incision biopsy where you have residual orbital lesion? So it's, although it melts, having a very microscopic residual is always good than, having a bulky residual as an orbital surgery is concerned. How do you go about it?
This is my thought. Like if it is on conjunctiva, I think I try to excise as much as possible without causing any problem. If it is in orbit, if it is in the lacrimal gland, and if you take the posterior part of the lacrimal gland, as I think I try to debulk as much as possible. I never attach or touch to the anterior part of the lacrimal gland. And then I try to make it smaller, basically. I think it makes for the radiation effect, maybe not the high dose radiation, but the Rituxan and the low dose radiation effectiveness increases if you debulk it.
Yeah, so I think the thing to highlight here is like the maximum debulking, of course, not causing any damage to the sensitive ocular structures would definitely help in, kind of avoiding the recurrence when you're playing around with the dose in orbit. Yeah. Thank you.
Wonderful. These are all great comments and great talks. And now we're going to move on to some wonderful cases by some excellent surgeons and clinicians. So Lauren Dalvin from the Mayo Clinic in Rochester, Minnesota is going to kick us off today. Her case will be discussing an unusual epiretinal membrane. Lauren.
Thank you. It's a pleasure to be here. Thank you for organizing this wonderful session. I've learned so much today. So I'm going to talk about an unusual epiretinal membrane. And these are my disclosures, none of which are related to this case. So this was a 57-year-old gentleman with good vision, good pressure, who presented to a retina specialist with vitreous opacities, retinal whitening, and some hemorrhages in the left eye. So you can see that here. Again, vision's good, not really symptomatic at this point. Relatively normal OCT. You can see a little bit of debris in the vitreous. So the retina specialist sent this patient for some blood work, but over that time, 5 weeks later, this progressed. So you can see now we have increased retinal whitening, we have more hemorrhages, we have some vascular tortuosity, and on OCT here, you can see this thick band of epiretinal material that's deposited, and then you can see a little bit of intraretinal thickening as well. We can see on angiography, you get this hyperfluorescence around the vasculature with some late leakage that was really reminiscent of a vasculitic type of picture. So they did a vitrectomy trying to get at what the cause was for this. They sent it for cytology, which didn't show anything. Viral PCR was also negative. But the patient had rapid progression of this epiretinal membrane-like material over a period of 3 weeks that actually caused them to become symptomatic with a drop in their vision to 20/50. So you can see now much more thickening of this epiretinal material. And being very astute, the retina specialist is thinking about this patient's other history. And the background is that this is a patient with metastatic HPV-positive tonsillar squamous cell carcinoma. So we're very suspicious, not only for potential malignant involvement, but this patient's also immunocompromised, currently on treatment for this. So it's really important that we get to the bottom of what's going on. And so they were actually able to do a diagnostic peel of that epiretinal material. And so here you can see we have epithelioid cells with cytokeratin positive staining, and that confirms the diagnosis of metastatic squamous cell carcinoma. And there was persistent retinal infiltration, and that's the point at which they referred them to me for some help. So you can see here this thick intraretinal material. We also have some vitreous debris. So again, we're looking at a retinal metastasis, and I decided, looking at the literature and what this type of cancer might respond to, I gave a single injection of just 10 micrograms melphalan because, again, this patient is symptomatic. And we got a great response with just one injection. Just 4 weeks later, this patient had an improvement in resolution of floaters. Visual acuity was back to 20/30. They were very happy. Their quality of life was improved. Unfortunately, systemically, they didn't do well, and they ultimately succumbed to their metastatic disease. But some important learning points from this case: we know that vitreoretinal metastasis is a really rare entity, but if you're seeing a retinitis or vasculitis type of picture, especially if the patient has known underlying cancer, it's really important to keep this in your differential. Vitrectomy may often provide insufficient diagnostic material, especially if there's just not a lot floating around in the vitreous. And we don't always like to have to jump right to a full thickness retinal biopsy due to the risks. So if they have this thick epiretinal material, you can peel this, and that may be a less invasive way of getting your diagnosis. And then sometimes we don't have to do a lot to really make a difference in these patients' lives. If you can give one intravitreal injection and it makes the patient's quality of life better, that's very meaningful. So thank you so much. It's been a pleasure to present this case, and thanks for having me.
Lauren, a wonderful case. It's terrifying also to think that just an epiretinal membrane could look like that. I was interested to see that the OCT started to show almost like a annular or kind of formed ball within the anterior retina, which again is atypical. Amin, have you seen many of these intraretinal metastases, and any thoughts on surgical technique to approach this type of membrane removal? Anything different that you would do?
I haven't seen any of these, at least because it's quite rare. We have seen with the newer treatments for skin melanoma with the immunotherapy that we do have a few cases with metastatic intraocular melanoma. And that looks like a small sheath over the retina, and is pigmented, not quite like yours. But for that patient, what we did is we did a vitrectomy, and we did like a whole vitrectomy. And generally, if I do a vitrectomy, I will just debulk everything and remove all the membranes. But it is challenging, and if a patient has indeed a history of any cancer, then even with maybe the atypical epiretinal membranes, you should be aware of that it can be a metastatic disease.
Sarah, I saw you nodding. Sometimes when we take these tumor biopsies in melanoma patients, we can see a few pigmented cells that might trail from the tumor. Your experience with dealing with those residual cells, do you need to treat those? And then also, if you can comment on metastatic cutaneous melanoma to the eye and your approaches. I think you're muted, Sarah.
For me?
Thanks.
Yeah.
Yeah.
So we actually have a patient that had metastatic melanoma skin to the vitreous, systemically stable, iris one eye, we plaqued it, the cornea kind of went to pot, but the other eye developed the vitreous involvement. And they did a vitrectomy, and of course, they developed recurrence at the site of the port. So we had to plaque that area. We do the melphalan injections to the vitreous, but it was really hard to control. And I think it took about 6 injections, 20 milligrams of melphalan monthly to try to get it under control. So I think we're going to be seeing more and more of this. I think this is very hard to control. And it makes it difficult because systemically they're doing A-OK. But really, the eyes are quite challenging.
Lauren, it scares me that we are so eager now to put melphalan into adults when we're so worried about the toxicity of melphalan in children. What are your thoughts on on dosing, on safety? We see some really like remarkably bad toxicity profiles in kids. Tell us a little bit about this, and are there alternatives to melphalan? Should we be giving topotecan in these cases, for example?
Yeah, it's a really great question. And I think it maybe depends on the type of cancer that we're dealing with. For this one, I really dug into the literature and I just happened to find systemically that this type of cancer probably will respond to melphalan, which is why I had gone to that drug. In adults, if I use it, I tend to like to start with a 10 microgram dose. I don't usually do the 20 that I would often do in a child. For that specific reason of toxicity and not knowing how it's going to respond, I really intentionally did 1 at a time dosing. And as soon as the patient was happy, in this case, I stopped. I wasn't going to give additional unnecessary doses. But for other things like melanoma, I agree with Sarah, those can be really difficult to control.
Prithvi,
Very nice.
so the real issue with cutaneous melanoma is none of the drugs that we have available that we inject work for cutaneous melanoma. The melanoma oncologist will tell you none of them are the drugs of choice. So that's one of the real challenges, is that we're injecting things that we know we can do for other tumors. But for cutaneous melanoma, they're just not great.
Thank you. We'll move on to our next case, a mystery case by Vicky Dai, who's joining us from Israel. Vicky, take it away.
Okay, thank you. So while I'm uploading it, I want to thank you again for the wonderful collection of talks and for the opportunity to present this atypical case of granuloma in a small child. So the case takes us back to 2014 when a healthy 10-year-old girl was presented to us with previous presentation 7 years earlier at the age of 3 to another hospital where she presented with uveitis, vitreous hemorrhage, and granuloma. She had a full uveitis workup there, and she was found to have antibodies to cytomegalovirus and toxocara. And their working diagnosis was toxocariasis with granuloma. And she underwent pars plana vitrectomy there, and they said in the chart that the specimen was sent for cytology, but no answer was found in the chart. And then several years later, she presented to us with recurrent hemorrhage. She was sent for a second vitrectomy with the same working diagnosis. And before the vitrectomy, ultrasound showed the touch retina with full hemorrhage and hyperechogenic mass with the inferior temporal membranes coming from the mass with high internal reflectivity on A mode. And she underwent the second vitrectomy with PCIOL implantation, and the surgeon reported that the vitreous was full with VAH. And when the vitreous hemorrhage was cleared, she saw a superior-temporal mass located very near the vitrectomy port. So she took out the trocar and moved it to 11 o'clock. And the child was under OCT follow-up with no change to the mass. But then 1 year after the second vitrectomy, she presented with this black dot on the surface of her eye. Looking into the vitreous, we could actually see the dark lesion with the membranes coming off the lesion. And the thickness of the lesion was almost 10 millimeters with base of 13, high internal reflectivity and no internal vascularization. So we biopsied the lesion and we confirmed malignant melanoma epithelioidal cell type with 50% monosomy 3 positivity. And her final diagnosis was choroidal, ciliary body choroidal malignant melanoma, masquerading as granuloma in a small child. And she was treated with iodine 125 plaque. And as you can see, the extraocular, iatrogenic extraocular extension slowly regressed, and so did the tumor, regressed very, very nicely. And looking at the literature, we know from the Polish cohort that malignant melanoma in children is very rare, about 1.4%. And in the Shields cohort, it's also about 1%, with much better prognosis than in adult. Same was reported by the Finnish cohort, and the collaborative ocular oncology group of the European group also showed that the prognosis in children is better. But what about the eye? So she did regress very nicely, but then 5 years post-plaque, she began to show melting of the surface with irregular sclera, with no regression of the tumor, and she proceeded to perforation. So think what would do with this perforation? Looking at the literature, there are many, many options, none of which is very, very successful. So we started with putting a patch of cornea and amniotic membrane on top of it, but this didn't hold. The patch regressed. So we put a scleral patch with amniotic membrane, and that slowly incorporate into the tissue. And these days it's not even notable, and she's doing very well. So to summarize, this is a case of a 10-year-old, possibly 3-year-old child with ciliary body choroidal epithelioidal cell type malignant melanoma masquerading as uveitis and granuloma. She had extraocular extensions, probably iatrogenic one, 2 vitrectomies. She has monosomy 3, but she's followed up. She's now 10 years followed up by us and 7 years elsewhere. She's doing well. She has no secondary disease. She has good glaucoma control, good vision, but we hope her prognosis both systemically and ocularly will be good. And thank you for the opportunity to present this case.
Wow. That is terrifying. Sam, do these patients come into your clinic all the time? This is terrifying. Any comments?
I've never seen that, thankfully. Not yet, at least. No.
I guess one question is, what about systemic surveillance, Vicky? How many decades do you plan to survey her? I've had some children, and the parents, they get tired after a while of taking kids in for systemic surveys. Your thoughts?
So I'm telling them that I will try to look after them until the age of 119, and between 119 and 120, they don't need to be followed up by a doctor anymore. So lifetime follow-up, that's it. No exceptions. I don't have so many patients at this age, but
yeah, no. Thankfully, none of us should. Professor D'Amato, comments on this case, please.
It's a unique case. I've seen patients, young patients, as young as 11 actually, with melanoma, but not presenting like this. And I've monitored them the same way as in adults.
Lauren, any comments on this type of diagnostic challenge? You know, these are cases where patients go to vitrectomy, and does that change your idea of local therapy in the same scenario? Say it's an adult. Are you worried that the eye has been violated so much that you can still try to save the eye, or would you move to enucleation?
Yeah, it's really a personalized discussion. In some of these cases, we have proton irradiation now available where I am. So sometimes it's nice to do that, and I can have a little more control and customization with the radiation field so that I know that I'm going to cover everything, such as I'm going to cover a port site and not miss an area of extraocular extension, or I'm not going to further surgically disrupt things when I'm doing plaque placement and mechanically seed another location. But I think these are really critical discussions with the patients. We don't have good evidence to know if we try to save the eye versus if we remove the eye, does that make a difference in their ultimate survival? We don't know.
I mean, you're sitting in Rotterdam and one of your colleagues calls you from another part of the world saying, I think I'm in the eye right now of a vitrectomy and the patient has a melanoma. What are you telling that surgeon at the moment? Because there are a lot of VR surgeons listening in today.
I would say close up and send the patient in to an ocular oncology center. Because
So
I have had this patient where a colleague just was starting a vitrectomy and didn't notice the melanoma, and then the patient was sent in. But I will just do the general approach, and if she hasn't done any surgery at the moment, hasn't removed anything, I would just treat the tumor in any way and do a close follow-up.
I'm still on the phone with you, and I do transconjunctival sutureless surgery. Do I need to suture those sclerotomies when I come out of the eye?
If you haven't touched the melanoma, I would just remove the trocars and then just send in. You do not have to suture them.
There you go.
What about cryoing the ports? It's a pretty trivial thing. It's not going to cause problems, and it can only be good. What about cryoing the ports?
I
would agree with that.
I don't do that.
Yeah. I think that if it's a surgeon who's in trouble recognizing the scenario, I think, get them out of the eye as quick as they can, close it up. Cryo doesn't hurt if you have it available, and then immediate referral. But you don't have to finish healing that faint epiretinal membrane at that point. I think you can move on to bigger issues. Wonderful case. A lot of good discussion points. So we now turn to my good friend Vishal Raval from the LV Prasad Eye Institute, a clinician scientist in so many ways, and he'll be talking about an atypical retinal tumor in an adult. Vishal?
Yeah, thank you, Prithvi, for the opportunity, and I'd like to thank the AOS for organizing such an important ophthalmic ocular oncology conclave. And I'm eager to learn and share my interesting case, and directly jump onto my case. Is an atypical retinal tumor in an adult. The patient is a 45-year-old female, complained of gradual diminution of vision in the last 4 months. There was some vague history of injury, but there was no evidence of any open or any closed ocular injury. As you can see on torchlight examination, you could see some kind of fluffy exudates kind of seen in the retrolental area. The visual acuity was counting finger close to face with growth grade 4 RAPD with normal intraocular pressures. On intraocular, on cleaning fundus examination, right eye was absolutely okay, whereas left eye, you could see on a closer examination, there was white fluffy exudates kind of sitting right in the retrolental area with some kind of vitreous hemorrhage and inferior exudative detachment. On B scan was ordered, which again showed a kind of solid homogeneous lesion kind of arising from the retina, but some kind of underlying choroidal involvement also. So we made a clinical diagnosis, particularly in this age group, where we see a kind of a large solid homogeneous lesion, particularly arising from the choroid. Usually we make a diagnosis of choroidal metastasis with unknown primary. Yes, as a retina specialist, we do sometimes come across endogenous endophthalmitis. The fungal granuloma was also taken into consideration. So PET CT scan was ordered, which showed kind of some highly metabolic areas in the eye with low FDG uptake in kind of few cervical nodes. So the plan of management was to kind of do a fine needle aspiration biopsy from the lesion. Being a retina specialist, it was kind of go in and go out kind of procedure. And this sample was sent for both patho as well as for microbiology. The microbiology reports were kind of negative for any kind of fungal or an infective etiology. And the pathology, what we saw, kind of cells showed kind of loosely arranged in few clusters as well as in scattered arrangement. On closer look at 40x, you could see there was hyperchromatic nuclei with moderate pleomorphism, occasional mitosis, and background showed some kind of variable necrosis. But important feature of what we do is of the immunohistochemistry, what we have in-house, and it showed kind of HMB45 melon A as well as CD20 negative, but the synaptophysin, which is a very specific marker for neural cell origin tumor, which came positive with Ki67 close to 60% positive. So the cytological diagnosis again was kind of very dilemma, particularly in this age group. Are we dealing with a neuroendocrine origin of tumor or very rare presentation of retinoblastoma in this age group? Considering the extent of the lesion and the uncertain diagnosis, we gave a choice of enucleation, and the patient agreed to that. On enucleation, again, you could see this is the kind of gross specimen. We could see the tumor arising from the kind of retina, but involving the major part of the choroid and involving the vitreous cavity. This is a kind of scanner view. Again, you could see there was a large tumor involving more than 50% of the vitreous cavity originating from the retina, but also involving more than 90% of the choroid, with few 1/3 of the scleral fibers also involvement. So the immunohistochemistry again showed kind of lesion cells which were kind of medium to large size with scanty eosinoplasm pleomorphism, and were very characteristic pattern which is very rarely seen in retinoblastoma. That is perilithiomatous pattern, where the tumor cells kind of arrange in around a larger central retinal blood vessel, and the Alcian blue stain was kind of negative for any kind of background matrix. Immunohistochemistry, again, synaptophysin was positive with neuron-specific anolis positive, CD56 and Ki67 60%. So considering the immunohistochemistry and the clinical morphology of the tumor, what we saw, we made a histopathological diagnosis of left type poorly differentiated small blue cell tumor with IST kind of confirming it to be a retinoblastoma. The final diagnosis what we made based on our clinical as well as pathological examination was adult onset retinoblastoma. Patient was advised for bone marrow biopsy, CSF cytology, both were negative for atypical cells, screening for progeny, where recommendation was genetic testing, how the patient denied for going for any kind of genetic testing. And treatment, because we had there's a massive choroidal invasion and 1/3 of scleral fibers were involved, we do as for any other children with retinoblastoma, particularly orbital, high dose vincristine VEC protocol, 6 cycles followed by EBRT, followed by 6 more cycles of high dose chemotherapy. So my question for panelists is, because this is a very rare presentation of retinoblastoma in this age group, so whether it is a de novo or reactivation of retinocytoma, particularly from the histopathological in-house studies, what we have seen, there might be a small area of retinoma or retinocytoma from where these tumors might in the late age presentation, where it might reactivate and form a kind of aggressive retinoblastoma tumor. And a special diagnostic testing, what we did, which we usually do for research purposes, that is CRX, that is cone rod homeobox, and this again came out very strongly positive for retinoblastoma. So I think when doubt, I think you should always go back to your immunohistochemistry as well as if any research-based tool, particularly CRX markers, if you have for retinoblastoma. I'll be happy to take any questions. Thank you.
Wow, what a case. Sam, do these patients come into your clinic?
So it's just children in our center. So no, but yeah, I agree. Absolutely fascinating case. And
do you think that this could be reactivated retinocytoma? What's your thoughts, and what would you predict genetics would look like?
I do think so. Yeah, I think that's likely. And if I think the genetics would be useful. So it's a shame that we won't get those. But yeah, I suspect a reactivation of a retinocytoma.
Bhavna, any comments on this type of older age presentation, which you may be seeing more in India than we would see here?
That's true, Prithvi. We do have seen a few cases of adult onset retinoblastoma, and a couple of them presented with an intraocular mass the way we saw in this case. In fact, I remember one patient who presented with adult onset retinoblastoma had an orbital mass. And, so in that situation, we went ahead with a biopsy and we found that it's retinoblastoma, and we were pretty surprised. So yes, adult onset retinoblastoma, we have seen a few cases, and treatment remains the same as we do for children. And basically, like Vishal pointed out, that yes, genetics can be very important. And I do agree that these cases could be a situation where it's actually a case of retinocytoma undergoing a malignant transformation, as we know from the paper by Professor Arun Singh, that, like a certain percentage of retinocytoma cases can undergo malignant transformation and they require lifelong sort of follow-up. So yes, this could be one of those cases.
Can I make a comment?
Please, yes.
Vishal, excellent case. Yeah. So in my cases, in my series, I have a 34-year-old and a 57-year-old. So the 34-year-old had a very typical vitreous seeds, which was like very, clinically representative of how we see the vitreous seed, and a white lesion, which was sitting there. So there was no diagnostic dilemma in that. In the 57-year-old, it was a large tumor. In fact, it was a very large tumor, probably, which was sitting there, for a long, long time. Yeah. And yeah, so.
A question to everybody. Treating adults with pediatric recipes for retinoblastoma treatment, do they tolerate it as well as the children do? Different toxicities to think about. Vishal, any comments?
Yeah, I think we don't have that much of literature to support the evidence whether the same protocol what we use for children which is going to work for adults. But I think whatever the scarce literature what we have, I think the treatment remains the same whether it is adult or pediatric, and the dose, but obviously it ranges from the bone marrow, sorry, the BSF what the patient has, age and height. And in our case, the patient has already undergone 2 cycles. Unfortunately, we couldn't save the eye, but I think the important part for us, learning point for us, is that being retina specialist, whenever you see this kind of presentation, always keep the evidence of intraocular malignancy, especially retinoblastoma, in your kind of differentials.
Wonderful.
There was this 16-year-old who presented with, it was very typical of a retinocytoma, but there was some activation in it with vitreous seeds. So what I did was I went ahead doing an intraarterial chemotherapy for her, 2 cycles, and intravitreal topotecan.
Excellent. Yes.
Did you maybe ask in the history if something happened? I don't know, maybe they were receiving some steroids for something before the activation occur, or maybe some severe illness was there, something that would maybe reduce their immune system. Or I'm just trying to see if there is something environmental that could explain why would the retinocytoma become active at some point of life.
I think the genetics might kind of give us some answers to that. I think that's where I think the crux lies, particularly for adult onset retinoblastoma. Unfortunately, the patient didn't agree. This patient,
case, wasn't it?
It's a unilateral.
So,
Prithvi, one thing with intraarterial, as they get older, you can go through the radial. And so most of our interventionalists will say it's slicker, it's faster, it's easier. They don't have to worry about the femoral. And I see Sarah nodding her head. I know that they're doing a fair amount of radial as well in Philadelphia on some of their cases.
For sure. So we're coming to towards the end of the session, but we cannot end without having the wonderful case by Dr. Rajanaporn from Thailand. Maybe an RPE tumor.
Can you hear me?
I can hear you. You want to share your screen?
Yes, I'm sharing my screen right now.
Thank you. Perfect.
It's a wonderful meeting. Thank you for having me. It's my honor and pleasure to be here. I'm going to present an RPE tumor case. This is a case of 71-year-old Thai female, healthy, with decreased vision in her right eye. Her visual acuity was 20/100. You can see that she has the dark brown mass inferiorly with extensive exudative retinal detachment and exudate approaching the macula. Ultrasonography showed echo solidity mass with 13 millimeters in basal diameter and 7 millimeters in thickness. Autofluorescence show hypofluorescence of the tumor without any hyper autofluorescence. FFA showed early hypofluorescence of the tumor and moderate hyper in late phase, but ICGA showed hypocyanescence in early and late phases. The differential diagnosis includes PHDR due to the extensive exudates, but there's no hemorrhage and no drusen in the eye. Choroidal melanoma, unlikely they will produce a lot of exudates like this. Vasoproliferative tumor, usually they are non-pigmented, and you can see profound hyperfluorescence of the tumor, and it's usually non-pigmented tumor. RP epithelioma, which is a very rare tumor that can produce the exudates like this. The patient was initially diagnosed with PHDR and was treated with retina specialist by giving her the intravitreal bevacizumab and triamcinolone. You can see that after the treatment, the tumor quite regressed, the exudative reduced, but is not completely disappeared. She came to us and we performed a translumination test which showed tumor shadow, and FNAB showed foamy cells containing melanin pigment and rare benign epithelial cells. We thought that she has RPE epithelioma, so we performed ruthenium brachytherapy with a dosage of 80 grays at tumor apex. This is before ruthenium, 3 months and 1 year after the treatment. You can see that the tumor gradually decreased in size and regressed, and the exudates resolved. So in summary, this is a case of 71-year-old female presented with dark brown mass with profound exudative detachment and exudates, initially treated with triamcinolone and bevacizumab, which show some tumor regression and some reduction in exudative detachment and exudates, and completely disappeared with the ruthenium plaque brachytherapy, as you can see here at 1 year and 3 years after the treatment. The visual acuity improved from 2100 to 2040. Thank you very much for your kind attention.
Wonderful case. Professor D'Amato, these are rare tumors. We just saw with the initial management by the retina specialist before Dr. Rajanaporn, again, the use of Avastin that helped the exudates get better, and the tumor almost looked a little smaller. So your thoughts on managing these cases, do we need to treat them always?
I think if the exudates is increasing and the mass is not resolved, this is almost a year after they inject the Avastin and triamcinolone many times, and then the tumor is still active and causing the exudates. So I think a plaque brachytherapy is a good choice in these cases. But in cases that is not active, then you may observe.
Professor D'Amato, your thoughts?
I think if it's a large tumor like this, I would treat it with ruthenium plaque. Interestingly,
which
we had
dose
a
would you use?
ciliary
Dose
body.
of ruthenium?
Bertil, what would be the dose you would use?
Yeah.
Well, my standard approach is to give a minimum of 350 to sclera and a minimum of 100 to the apex. Because with ruthenium, the dose of radiation drops rapidly, and so you're only going to radiate vitreous. It's not going to cause any problems. It's very different from IOD.
Do you use the same doses like in melanoma?
Yeah, a melanoma, I give high doses like that.
Bhavna, when you treat these with radiation, would you also treat to melanoma dosing or take a different approach?
Well, I would use the same dose, a high dose, just to be sure. Because I can afford to do that with a ruthenium plaque. With iodine, you can't do that.
Can you explain why the tumor regressed partially after triamcinolone and some Avastin? Do you think it plays any role? Or in case that you have a larger tumor that ruthenium cannot cover the thickness, can we do the injection of the Avastin or triamcinolone before we do the plaque to allow the tumor to regress further?
Lauren, I'm going to direct that to you. Any comments? Avastin seems to work.
Yeah, are you asking intra-arterial Avastin, or you're just talking intravitreal Avastin?
It looks like this patient got
intravitreal
intravitreal and with steroid. Clearly, the
Yeah,
exudates got better, but the tumor also got a little better.
Yeah, I don't know that you're going to regress a large mass solely by doing intravitreal. I think you could potentially reduce your radiation dose a little bit, and it would mainly, in my opinion, probably not be because of the tumor mass itself being reduced, but maybe you're getting a reduction in intratumoral edema that makes it look like the tumor is a little bit smaller. So that could give you a little more confidence doing a little bit of a smaller radiation dose field, certainly. And you would want to time that then so that you have your medicine still on board at the time you're going to have the plaque placement.
Amin, final question to you. Is there a role for local resection for these types of tumors, these RPE tumors?
Honestly, I don't know. I haven't done it.
I can answer that. We had a patient once who treated with a ciliary body tumor with proton beam radiotherapy. And the patient got quite severe uveitis after that, which didn't respond well to steroid drops and so on. And so I did an iridocystectomy. And to my surprise, it wasn't a melanoma, it was an adenocarcinoma of the ciliary body. And by removing the tumor, the problem was solved. So this was a sort of toxic tumor syndrome after proton beam radiotherapy for ciliary body adenocarcinoma.
Interesting. And these tumors look toxic to begin with because they leak so much lipid to start. These were wonderful cases, and I will summarize before turning it over to Professor Gombos that on behalf of my very smart friends who are experts in ocular oncology from around the world, we are grateful to the All India Ophthalmologic Society for allowing us to share some of the very exciting new and riveting changes in ocular oncology, and we look forward to participating with the society again in future. I leave us with the prophetic words of Professor Dan Gombos to close the session.
So I would like to emulate everything you just said, just some really amazing talks. I think we continue to see how principles from general medical and surgical oncology continue to pervade into ocular oncology. We're seeing how molecular diagnostics are playing a more significant role, both in prognostication, but increasingly in management options. And what we're seeing is that we're having these patients live with globe salvage and live with, sometimes in cases presented today, really good visual outcomes. So we really see the evolution and the continued need to stay on top of the field because literally it's changing monthly. And I, like everyone else, learned a lot today. I'm grateful for everyone's participation. So thank you.
Rulika, we turn it back to you.
Yes, thank you everyone for the wonderful session. We enjoyed every bit of it, the session and the discussions, and we're happy to have all of you. And thank you for sharing your time with us. We know that you're all from different timelines, so have a wonderful rest of your day. And moving on to our next session, it will be held in 14 minutes. Thank you, Dr. Prithvi, for keeping it absolutely on time. And our next session will be held in the same hall in 14 minutes on complex strabismus current trends. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you so much. Thank you
very
everyone.
much.
Bye.
Thank you.
See you. Bye-bye.
Thank you.